Boa tarde a todos, sejam muito bem-vindos ao nosso Simpósio Merck. Prazer poder contar com a presença de todos vocês aqui. Nosso simpósio intitulado A Importância de Superar a Inércia Terapêutica no Tratamento da Icfer, pela titulação dos 4 pilares de tratamento. Meu nome é Leonardo Marino, sou gerente médico da franquia de cardiologia da Merck. Dando prosseguimento aqui à nossa sessão científica, gostaria de chamar ao palco os nossos 2 moderadores da sessão, doutora Lidia Zytynski Moura, que é a atual presidente do Departamento de Insuficiência Cardíaca da SBC, professora titular da Escola de Medicina e Ciências da Vida da PUC do Paraná, doutora pela Faculdade de Medicina da USP, coordenadora do Serviço de Cardiologia do Hospital Marcelino Champagnat e Hospital Universitário Cajuru, da PUC Paraná. Gostaria também de convidar ao palco o Dr. Múcio Tavares de Oliveira, professor livre-docente pela Faculdade de Medicina da USP, diretor do Hospital Dia e Centro de Infusão do INCOR e coordenador do projeto de insuficiência cardíaca da SOCESP. Doutores, muito obrigado por terem aceito o convite, obrigado pela parceria de sempre, o palco é de vocês.
Muito obrigado, Leonardo. Eu estou dando a abertura da parte científica dessa sessão, então, antes de mais nada, agradeço ao Leonardo, a Thaís e a toda a Merck pelo convite para estar aqui. É uma honra estar aqui. E eu e a doutora Lidia somos os coordenadores desse simpósio, que tratará sobre um assunto de extrema relevância no tratamento do paciente com insuficiência cardíaca. Eu tenho certeza que todos, além do sanduíche, vão ter um grande benefício em estar aqui hoje. Passo a palavra para você, Lidia, para que você faça suas considerações e chame o professor Piotr.
Então, bom dia, né? Agora já quase boa tarde a todos. Primeiro, gostaria de agradecer a Merck pelo convite, Leonardo, Thaís, é sempre um prazer estar aqui na SOCESP. Eu acho que hoje é um momento de grande honra para nós, né? Para mim, pessoalmente, para quem não sabe, minha família é polonesa, então, para mim, esse é um momento realmente de falar uma língua que, para mim, é uma língua de casa, então não estranhe se eu falar em alguns momentos polonês, mas nós vamos ter a honra de receber o professor Piotr Ponikowski. O professor Piotr Ponikowski, ele é diretor do Instituto de Doenças do Coração do Hospital Universitário de Breslavia, na Polônia, que é Wrocław, mas o professor Piotr Ponikowski, ele foi, na verdade, chair da diretriz europeia, não dessa atual, mas da anterior, e acho que é uma das pessoas que tem o maior conhecimento em insuficiência cardíaca. Então, não é somente alguém que faz as diretrizes, mas é alguém que tem visto os pacientes, alguém que trabalha muito tempo com as pesquisas em insuficiência cardíaca, uma linha muito consolidada, é o principal autor do CIBS-3, né? Então acho que é alguém que tem muito a nos ensinar. Então, por favor, recebam com uma salva de palmas o professor Piotr Ponikowski. Próximo.
Very good afternoon. Thank you very much for this nice introduction. With Lidia, we decided that we'll speak in Polish to make everyone happy, to make everyone remember this session, but it was just a plan, don't worry. Once again, thank you very much for your kind invitation. I am very glad that we will be now discussing very important issue, although in cardiology, we are very far. We are doing a lot of interventions. We are doing a lot of sophisticated procedures. Some of you may consider the topic, what about pharmacological therapy nowadays in the context of HFrEF patients, heart failure with reduced ejection fraction? I try to convince you that the problem is there, and we still are far from saying that we are we have received or obtained the success. That would be the topic, how to overcome therapeutic inertia in initiating and up-titrating the therapy. If only I can move the slides, maybe with, can you, okay, maybe with the mouse would be easier. Yes, thank you very much. So, okay, I would like to propose you the following outline. I would like to first introduce to the heart failure management very briefly. In 2023, we had the update of the guidelines in Europe. Then I would like to discuss with you what inertia really means in terms of not only the definition, but also some potential underlying factors, and discuss underdose and underusing of guideline-directed medical therapies. Last but not least, let me discuss with you the problem of old, if not very old, studies, randomized clinical trials with beta blockers in the context of contemporary HFrEF therapies. Let me start with this slide. We presented quite recently at the Lisbon meeting, summarizing heart failure in the 21st century in the context of unmet need. If you look at the title here, you will see the global burden of heart failure with a dramatically still valid and increasing prevalence. So overall prevalence is increasing. The incidence is very, very high. And if you look carefully, at least in my country, the incidence of acutely decompensated patients being admitted many times, so-called frequent flyers, is a real issue in my country and also in many European countries. The number of cases, so-called worsening heart failure, admitted to the hospital is much bigger than acute myocardial infarction now. So what else? Mortality is still far from being acceptable. 1 year mortality in everyday life is nearly 15 to 30%, with 5-year mortality of around 50%, which is far worse than in many malignant disease. And we would like to highlight here that non-cardiovascular disease, they start being the important component of mortality, and the cost is really an issue, the economic burden we need to remember and consider. There is another story about this, a little bit artificial maybe, the definition of HFpEF, MREF, and REF, but if you look at the lifetime risk of heart failure of people with preserved ejection fraction, you will see that in women, it tends to be more towards PEF. In men, it tends to be a pretty reasonable equal numbers, but we all need to remember that both PEF, REF, MREF, they all carry a very high risk mortality morbidity. So there are 5 pillars, we would say 4, because loop diuretics, they still have a place in the therapy, but mainly for keeping the patient's euvolemic and symptomatic free or under control. For mortality and morbidity benefit, we have this RASI, including ARNI, beta blockers, MRA, and SGLT2 inhibitors with class 1A recommendation. This Greek temple, it seems to have not 5, but more pillars. I'm sure that novel therapies like omecamtiv mecarbil or maybe IV iron, maybe some other new drugs like vericiguat will form the future, but whatsoever we have 4 pillars. Let me draw your attention to this very interesting analysis. This is the analysis published by colleagues from Europe and America, and the publication is already from 2020, so 4 years. The message is with us. The problem was very straightforward. based on clinical trials, not on practice, on clinical practice, but based on clinical trials, are we able to improve improve the risk of mortality and morbidity in patients with HFrEF? What about the benefit over time? And this paper considered several data from several major trials with all therapies and came up with a very simple conclusion. If you consider comprehensive treatment nowadays with widely available 4 compounds, which I alluded to in the previous slide, you remember these 4 pillars, namely ARNI, beta blockers, MRA, and SGLT2 inhibitors, and compare with still so-called conventional therapy, you will see that combination of 4 drugs, widely available, easy to introduce into everyday clinical practice, is able to prolong life, not versus placebo, but versus active therapy, for many considered as a still conventional, by around 5, 6, even up to 10 years. If you take this benefit into consideration in the context of oncology therapies, which are able to prolong life by weeks or months maximum, you will see that this topic of today's discussion, how to up-titrate 4 pillars therapy, is of fundamental importance. Please remember this as a background for our discussion. This is the summary of the guidelines. Patients with REF, you already heard. I remember that in 2016, when I had the privilege to chair the guidelines, we introduced the concept of heart failure with mildly reduced ejection fraction. We were heavily criticized. We took this as a normal reaction from cardiology world, but it appears that this decision was I would say, timely and at that moment well appreciated, because now we see that this MREF is becoming an interesting entity, and we have this kind of a recommendation still with diuretics for fluid control, DAPA-EMPA for class 1 to prolong survival, and ARNI, MRA, beta blockers as class 2B indication. For PEF, as you remember, we have treatment of etiologies, cardiovascular and non-cardiovascular comorbidities, diuretics, and SGLT2 inhibitors. It brings me now, so that's the background, the stage is already set, the background is already there, so let's discuss the issue of clinical inertia. I remember that for the last 3-4 years, we keep saying that these 4 drugs should be on the board as soon as possible, and still less than 10% of patients are receiving this quadruple therapy everywhere, in Poland, in Europe, in America, and I'm sure also in your country. So we are discussing the problem of clinical inertia, which is the lack of treatment intensification despite the evidence-based recommendations. And the authors of this elegant paper alluded to several factors, system-related, we discussed politics behind this, patient-related, and physician-related, kind of a weighting that 50% of this suboptimal therapy is due to physician-related factors. And among those physician-related factors, there are several listed here. Physicians don't see an indication. Physicians forget to prescribe. Physicians consider the patient as stable, although he or she is not optimally treated, but not complaining. And finally, physicians' concerns about adverse effect. All things very well, all points very well taken, but please remember that obviously I am not saying that in clinical practice, these are the registries which summarize clinical practice. There are not obvious reasons which may preclude us for a quick decision, but this is not what should preclude us for initiation and up titration, because in the vast majority of cases, I will show you the data from STRONG-HF, this is an achievable goal, and we need to remember. And this is a very elegant cartoon presented by Stephen Green already 3 years ago, when he and his colleague tried to discuss patients' factors commonly associated with guideline-directed therapy. We all know that. We all accept that our patients are old, our patients are with many comorbidities, our patients tend to have a hypertension, etc., but also some other issues which are strictly on our side in order to improve the therapy. And it comes the story now about the underused and underdosing of guideline-directed medical therapies in terms of how to change it. This is the registry, the summary of 3 registries, very recent publication by Gianluigi Savarese, who is in Karolinska, and who takes all these databases together. And at this time, he took data from Japan, Sweden, and United States, 270,000 of new users of therapies. He followed this, or they followed this based on the databases, and after 100 days, it appeared that SGLT2 inhibitors and ARNI, they tend to be a little bit behind other therapies. But if you look at this, you may feel that we need to, or we are allowed to sleep well, because beta blockers, MRA, and AC inhibitors are on optimal doses, and they are initiated and they are in the therapy. But if colleagues look at what happened 1 year after, you will see that in many patients, which is presented here in red, the drug is discontinued. For beta blockers, around 25% are no longer on beta blockers. For sacubitril/valsartan, nearly 30%. For AC inhibitors and MRI, even more. And if you look at the optimal dosing, you will see that vast majority of patients, they tend to be on a suboptimal dosing of therapy in 2021, 2022. The same story in US and Germany, very recent publication just came out, a comparison between everyday clinical practice in United States and Germany, and I only highlighted the persistence after 1 year after initiation of the therapy in Germany and in the United States. If you look carefully here, you will see that 1 year after initiation of therapy, around 60 to 70% of patients still continue the therapy, whereas around 40% stop the therapy. And if you look at the mean time to discontinuation, it is only for 4 months. In other words, patients, at least 30 to 40% of patients with heart failure, they tended to be optimally treated only for 4 months. And the last, very novel, very fresh, make it this way, presented in Lisbon, data from Titrate-HF. Here we have a heart failure registry conducted in the Netherlands, more than 4,000 patients in Netherlands, so where the system is very well developed. And you will see that the percentage of target doses for each drug class stratified here by 50, between 50 to 100 or 100 and more optimal dosing is very poor. If, for example, you take beta blockers, 56% of patients are not receiving optimal dosing. If you take ARNI, 42%. If you take other RASi, half of the population. And here is the beautiful example which tells us everything. If you look at the quadruple therapy, which is depicted here center by center, quadruple therapy, you will see that in the Netherlands, between 10 to maximum 70% of centers tend to use optimal therapy. Here is 50% magic bar. You will see that still far, far below the average in the country. So I am not going to bother you more with the registry, but only for the last 3 years, 3 major publications are telling us about the underuse and underdosing of the therapy. Only recently, together with colleagues, we came up with the idea that perhaps in hospital initiation and early post-discharge initiation is what really matters. But to be honest with you, this is not that novel. This is the paper from Javed Butler he published 20 years ago, when he very clearly demonstrated that if someone receives ACE inhibitor here, but the same applies to beta blockers, to ARNI, to SGLT2 inhibitors, at discharge, the chance he or she, the patient, will continue with the therapy is much, much higher than if the drug is not prescribed at the discharge. This is another paper, another study quite recently published. I don't have the time now to get into the details. I just highlighted here that discontinuation or non-use of the therapy after hospital admission is obviously related to very high risk of deterioration. Here comes something which is, in my humble opinion, very important. Here comes the new paradigm story. For many years, we have not appreciated worsening heart failure or acute heart failure episode as the best moment to start the therapy, and the post-discharge period as the optimal phase to up-titrate the therapy. Before the meeting, we had a very good conversation with the both chairpersons, and I heard that you also have in Brazil the concept of infusion clinics. So you have a patient who is perhaps not at that high risk to be admitted, still with worsening heart failure, but then he or she enters here this discharge period when the physician can see him, her, many times during a relatively short period of time in this post-discharge period. And the concept of early initiation in this peri-discharge phase, guideline-directed medical therapy is with us. I don't have time to allude to all these randomized clinical trials. I can only tell you that I had the privilege to participate in all but pioneering HF. It was mainly America. And all of them proved very elegantly that the concept is that start the therapy, up-titrate, and continue. That's it. We have this study called Strong HF. It was not a study. It was indeed a trial, but not with a drug, but with a strategy, which I am going to discuss very briefly with you. We simply tried to randomize patients who were stabilized into 2 regimens. One regimen was to send patient home, but in this so-called high-intensity care. Within 6 weeks, we wanted the physician to reach the optimal dosing, but it was not 6 weeks. In fact, it was 2 weeks. Another 2 visits at week 3 and 6, they were meant for safety. So the optimization therapy after discharge should be done within 2 weeks only, not 6, 2. And the second arm was we send these patients home and ask physicians to do what they do in everyday clinical practice. There was nothing like a guided therapy. Do whatever, in your opinion, is the best for the patient. High intensity versus usual care. The trial was stopped by the data and safety monitoring area. We were very afraid that the trial was stopped because of safety. We were very afraid that the Data and Safety Monitoring Board, after only 1,000 patients, so half of the population, stops the trial because of deterioration here. In fact, the trial was stopped because of the overwhelming benefit in this high-intensity care. And this is the summary. We published this in The Lancet, that high-intensity care is associated with much lower risk of 180-day readmission for heart failure, and all-cause death also goes the same direction. But what I would like to draw your attention is how we did this optimization. Please remember that we didn't use SGLT2 inhibitors because it was done 2017 and 18, but with SGLT2 inhibitors as the fourth component, it would be even easier. So if you look at beta blockers, you will see that patients were meant to receive 50% of optimal dosing on the day they were discharged home, and then during week 1 and 2, vast majority of them received at least 50% of the optimal dosing of the therapy. 90% at week 2. The same for ACE inhibitors, the same for MRA. And this optimal therapy here in blue resulted in much lower all-cause mortality or heart failure readmission, much lower than in other therapies. So even if we have this 50 to 90%, we see, which is here depicted, it's not optimal. It's far from being optimal. What really meant for the patient was optimal dosing. So I believe that this trial results led to the conclusion by ESC, heart failure guideline task, to write very straightforward recommendation for the pre and post-discharge optimization of the therapy, intensive strategy of initiation of rapid up titration should be initiated before discharge and finish within a couple of weeks after hospital discharge, full stop. That's it. And this is another scheme, another straightforward approach. 4 therapies on board only within 4 weeks. Very straightforward, the same like in our study. For acute heart failure, if you have a choice between ACE inhibitor and ARNI, you stop ACE inhibitor, initiated ARNI and SGLT2 inhibitor, you continue beta blocker, you initiate MRI. For chronic, the same story. For de novo, very straightforward 2-step approach. ARNI beta blocker first, and then in 2 weeks, SGLT2 MRI, full stop, that's it. So very straightforward approach, if only we remember this. And my last part is about a component of this therapy, which is beta blocker therapy. Many of us tend to forget how important it is. We are now overwhelmed by the SGLT2 inhibitors, which is a fantastic development. We don't know how they work. We believe we know, but we don't. They work, that's fine. We don't care. But we are overwhelmed by this novel therapy and tend to forget that beta blockers were on the board more than 2 decades ago, and they constitute in the contemporary heart failure environment very important part of the therapy. Let me get back to the details. These are landmark classical trials. Then many of you don't even remember, which is okay. You don't need to. All positive. And here is the message from the studies. Beta blockers reduce all-cause mortality by 34%. All-cause mortality is not about heart failure hospitalization. It's not about cardiovascular mortality. It's about all-cause mortality. If you look at number needed to treat, here is 28, which is only comparable with MRA. 28. Well, hydralazine and nitrate is about African American patients, and that's okay, but only regarding pharmacotherapy, you can compete with MRA, you can compete with CRT, but far better than the other therapies. We need to remember that. Another story is about sudden death. This is what we have written in guidelines in 2016 for the first time, showing that across all these trials with beta blockers, there was a very clear message that the risk of sudden death is also reduced. Not many drugs tend to reduce the risk of sudden cardiac death. This is why this comprehensive therapy with sacubitril, valsartan, beta blocker, MRA, and SGLT2 inhibitor reduced the risk of sudden death so hugely that there is an ongoing discussion how to position ICD now in the current era of this optimal pharmacological therapy. Another part of the story is that all studies with contemporary heart failure therapies, including this magnificent four, ARNI, beta block, MRA, SGLT2 inhibitors, vericiguat, omecamtiv, ivabradine, they all work because they have, that's my very strong opinion, beta blocker component, because this is another different underlying pathophysiology of heart failure progression. And it looks like that only these combinations tend to work in terms of all-cause mortality, as you see here, and also in terms of reduction in cardiovascular mortality and heart failure hospitalization, no doubt. Another important issue, and here I decided to focus on CBIS2. I had the privilege to work in CBIS2 and CBIS3, and I remember very well how we planned CBIS3 versus enalapril. And I remember that now you may think this is a little bit academic discussion, not worth even to mention, but at that time we were very curious about dosing, about starting slow, starting low and going slow, not too slow. Now we see that all these informations need to be adjusted in clinical practice, but should never preclude us for kind of a optimization within a relatively short period of time. But get back to the dosing. Here is low dose, up to 3.75 milligrams per day of bisoprolol, compared with moderate and high dose, optimal dose. You will see that moderate and high dose tend to hugely reduce the risk of mortality and morbidity. And the worst case scenario is actually to withdraw the beta blocker therapy, which dramatically increased the risk of deterioration and dying. And this is why the authors made the conclusion that all efforts should be made to maintain bisoprolol therapy, obviously, by all means, based on individual patients' tolerability, if necessary, decrease the dose, but never withdraw. This slide can make you a little bit upset. What about this tolerability? What about this beta 1, beta 2 selectivity? This is gone. It's not that easy, it's not that simple, because I do agree that we have 3 beta blockers highly recommended by the guidelines, bisoprolol, metoprolol slow release, and carvedilol. We also have nebivolol, based on the senior study, but this is more for mortality and morbidity. But this selectivity can give us a hint for everyday practice. What is the population we may use a certain beta blockers based on their unique properties, and this beta 1 selectivity is important. And if I get back to this conclusion from CBIS, patients' tolerability and tolerance is of key issue. So if you look at this paper, this study, it was an experiment allowing to investigate the beta 1 receptor selectivity. You will see that comparing with metoprolol, well, I heard that still in your country, atenolol is pretty commonly used for hypertension, which, no, thank you. Do I look like that I need to drink? Yes, maybe if I finish, thank you. Anyway, very kind. So once again, bisoprolol, metoprolol, carvedilol, you will see that there is a undoubtful conclusion, beta 1 selectivity is with bisoprolol. Is this clinically important? I have selected several studies to show you a potential benefit. This is about patients who are not able to tolerate carvedilol because of dizziness and hypotension. And perhaps you remember that mainly due to alpha adrenoreceptor blockade, this vasodilation may well be important in the context of dizziness and hypotension, and you see that switch from carvedilol intolerance to bisoprolol in this population made these people able to tolerate beta blocker, bisoprolol, and they were even able to tolerate 5 milligrams, 40%, and there was a relief in symptoms, sign of dizziness and hypotension, which shows that this beta selectivity matters for some areas. Obviously, the issue which strikes or rings the bell immediately here is COPD. This is the study you do not remember, and I remember because we were very much afraid of this beta-1 selectivity once we were planning CB3 and once we were planning the study with nebivolol. COPD in the context of the lung function. You will see that very high dose of bisoprolol, it was European Journal of Clinical Pharmacology 40 years ago published, high dose of bisoprolol do not affect the lung function, here measured as an airway resistance, so flat line, very similar to placebo. It gives us the hint to believe that bisoprolol, this beta-1 selectivity, is preferable for COPD. Here is an interesting study. Actually, it was not a study, but retrospective cohort analysis with nearly 12,000 patients diagnosed with heart failure and COPD, with many comorbidities. If you look at the effect on survival, you will see that both, all three drugs, carvedilol, bisoprolol, and metoprolol, particularly in the high doses, once compared to low doses, they tend to work. However, statistical significance, there was only noted for bisoprolol, preferably high doses, pretty well tolerated by these patients. Another story, which is not necessarily now related to beta-1 selectivity, which is another issue for some other intolerance in male sexual impotence, or we can raise this during the discussion, is the issue of renal dysfunction. Beta blockers are the only drugs which seems to work across the whole EGFR, and again, there are several reports. They are also working. I'm sure that the chairpersons would raise this issue in patients who are in this pre-dialysis or even dialysis stage. We do not have the data at all. I don't have time to focus on that, but this is the analysis from CB3 showing that the effectiveness is there with bisoprolol in terms of the clinical benefit across the whole spectrum of EGFR. Last but not least, what the guidelines are saying, 2021, in the context of beta blockers, navigating the current guidelines, focus on beta blockers, all patients with HFrEF, the beta blockers are recommended, class 1 recommendation, to reduce mortality, morbidity, and to improve symptoms. They always should be a part of the therapy together with the other elements, should be initiated in patients who are euvolemic, gradually up-titrated. It is 2021. We are now in a better position. We know what gradual means. We can have this within 2 weeks. And obviously, we still should pay attention on hemodynamic stability, and that's the recommendation. 2BC recommendation for patients with heart failure with mildly reduced ejection fraction. These are American data. The same story. I would like to draw your attention to this part. Even when asymptomatic, or even when symptoms are mild or improve with other therapies, beta blockers should constitute a part of the therapy. And this is very important as well, because we are seeing more and more patients with so-called improved ejection fraction. Patients are approaching us and saying, I am in a pretty asymptomatic, obviously the wording is different, they are not using asymptomatics, but they are saying they are doing okay. They don't have symptoms, their ejection fraction is in the range of 50, 55. Shall I continue? Yes, sorry to say, we can't say no, because we don't have the evidence, and the Americans are saying, even in symptoms or ejection fraction tend to improve, long-term therapy with beta blockers should be kept, should be maintained. That's what are in the guidelines. Last not least, what we have learned, beta blockers remain the core of the modern heart failure treatment. Treatment of beta blockers improves the outcome, reduces symptoms. What really matters is the main issue is to use them in all patients across the whole spectrum of severity, across the whole spectrum of GRR, in the elderly, in comorbidities, and always remember that even if there is intolerance, even if there are symptoms which may occur, I do agree, particularly in these elderly, frail patients with comorbidities, with advanced disease, try to up-titrate the dose and try to keep the therapy. That's what I wanted to conclude. Once again, thank you very much for your invitation, and I'm ready for questions.
Thank you, Professor Ponikowski. It was a very nice presentation. Nós estamos abertos agora, nós temos uma sessão de perguntas e respostas, nós temos vários microfones disponíveis. As perguntas podem ser feitas em inglês ou em português. Temos uma.
Meu nome é Carlos Azeredo e gostaria de saber do professor Piotr, em caso de bronquite asmática, qual é a recomendação para os pacientes com insuficiência cardíaca?
A doutora Lidia vai fazer essa pergunta para o professor Ponikowski em polonês.
On się pyta, jak będzie miała astmę, czy może używać astma.
COPD and asthma, there are two different things. Yes, I do agree. If you have asthma with several deteriorations, obviously we may debate whether this is not absolute contraindication. You may say it may be considered to initiate with a low dose, and here better selectivity due to this responsiveness of the lung is of key importance. And I think that particularly in HFrEF patients, you have nothing to lose. And I would definitely keep this as a part of the therapy.
Mais alguma pergunta? Vocês já viram que a gente está traduzindo em todas as línguas. Por favor, fiquem à vontade. Essa foi...
Eu vou fazer uma pergunta enquanto a plateia se aquece. I'll do the question first in Portuguese for the audience, and then I'll do it in English, or Lidia can do it in Polish.
Well, both options are preferred. It's okay. Yeah. I'm sure there are many Polish people at the audience, so we can easily switch. Okay.
O estudo Strong Heart Failure foi uma marca, foi landmark no aumento das doses das drogas recomendadas pelas diretrizes para pacientes com insuficiência cardíaca. E esse estudo usou o NT-proBNP como um guia para que as doses fossem aumentadas. Então, os pacientes que tiveram uma queda no NT-proBNP, as doses eram aumentadas de forma mais rápida. Eu vou perguntar se o Dr. Ponikowski acha que nós termos um valor numérico nos ajuda a melhorar ou aumentar com mais segurança as doses. Professor, this strong heart failure was a landmark study about up titration of drugs, and one of the issues in this study was the use of NT-proBNP as a guide for increasing or having be more cautious or be more do it in a hard way. Do you think that we have a numeric guide would help us to improve the titration of the drugs?
Well, great question, and the matter of controversy for at least 15 years. Just to correct, I'm sorry, I'm not going to disagree, but a small correction. NT-proBNP in strong HF was not part of an up titration regimen. First of all, in strong HF, we only included patients who tended to have a decrease in NT-proBNP from baseline to the discharge, which is important, which is very important sign of improvement, because if someone starts with a very high NT-proBNP and before discharge the NT-proBNP is still high, if not higher, then he is not a candidate for the trial because he or she is not optimally treated, not euvolemic, etc., etc. So there was a requirement for NT-proBNP decrease before the study initiation, number one. During the 4 visits, the decision how to up-titrate the therapy was not related to NT-proBNP. NT-proBNP was a safety measure, similarly to creatinine and potassium, and only if elevated, then we ask the physician to increase the diuretic therapy. So in fact, NT-proBNP was not meant as a guide for guideline-directed medical therapy, but more kind of a safety volemia issue. Number 2. Number 3, sorry to disappoint you, there is no magic number whatsoever, but monitoring of this very important biomarker can help a lot. I don't know whether so often like we did in a strong HF, but helps a lot.
Eu vou fazer uma pergunta para ele em polonês, então acho que eu preciso de tradução, essa fica mais fácil, mas eu vou falar a respeito do Strong HF, porque nós tínhamos, assim, por ser uma população europeia, nós tivemos uma população de idosos, e eu acho que uma otimização de 2 semanas numa população de idosos deve ter sido uma coisa desafiadora. Então, vou perguntar, na verdade, quais foram os desafios nessa população de idosos e que tipo de estratégia eles usaram, ou se foi uma coisa simples e basicamente foi o protocolo. Jeszcze się zapytać w Strong HF, jak to było, żeby w 2 tygodniach w tych pacjentach powiększyć te lekarstwo, bo to są starsze osoby, to było ciężej, to było to samo, jak to był protokół w tych osobach, bo to jest starsze osoby.
Well, I understand the natural fear and intuitive approach that if you have a patient with heart failure, with particularly the older patient, frail patient, the up titration of the therapy may well be a challenge within 2 weeks. But I tell you what is, in my humble opinion, needed to change this paradigm. Oncologists, they initiate therapy, this adjuvant therapy with chemotherapy in an absolutely super aggressive way. To be honest with you, they don't care about the side effects. They don't. If side effects, life-threatening side effects occur, they consider down titration or withdrawal of the therapy. In heart failure, we have done for many years the opposite. We started the drugs with a very tiny dosing and looking forward whether something happens. If something happened, not necessarily due to these drugs, we said, no. We can't really increase the drug because the patient is not able to tolerate the therapy. This was absolutely opposite to what the oncology world is doing. I personally believe that strong HF has given us the mandate to believe that if you consider these 2 visits, in every week visit, with a careful and very thoughtful approach, I don't know whether this is possible everywhere. It was possible in these centers who participated in the trial. I'm sure that not everybody has got such a resources to call the patient in one every week 1, week 2, week 4, week 6, and to say, okay, today I examine the patient, despite he or she is elderly, frail, with blood pressure over 100, and I will double the therapy, and I will see what is going to happen. Nothing happened. But we made sure that nothing happened because we monitored the patient. And if something happened in 10% of these patients, then we would not increase it further. So I think this is just a natural approach which we need to change. That's, I hope, answers the question. We need changing in our mindset to approach patients with heart failure and reduce ejection fraction. I think obviously following him or her on a very careful way. That would be my answer.
Dziękuję. Perguntas da plateia, por favor. Vamos lá. Por favor, microfone.
There. Just one curiosity. Why the CIBS-1 doesn't achieve good results like CIBS-2? You can explain, please?
I tell you, CIBS-1 was a trial with dilated cardiomyopathy, with only 800 patients. And I am very glad that colleagues, I'm sure that the rest of the audience is too young to remember, we both remember CIBS-1. It was 1986 when there was a first publication in British Heart Journal and then in The Lancet about patients treated with beta blockers with heart failure with reduced ejection fraction who miraculously improved. Nobody knew why. Everybody took for granted that it was something wrong. And then colleagues from Sweden, from Scandinavia, they started with CIBS-1 in dilated cardiomyopathy patients with 800 patients, and they had a signal, very strong signal, you're right, that there is improvement in mortality and morbidity. And luckily, small study, 800 patients, a good signal, etc. Today, no one would plan the study this way. Everybody would go either for win ratio analysis or for 7,000 patients trial. At that stage, the development of trials was different, but luckily, those in the development of the program didn't consider this lack of P005 as evidence that beta blockers bisoprolol doesn't work. That would be my only answer for this. Just good luck that they did not consider this as a neutral effect.
Thank you, sir.
Alguma pergunta da plateia?
I've got a
Ali
question.
no fundo.
So, Professor, in a patient with a heart failure and reduced ejection fraction and with sinus bradycardia at baseline, would you implant a pacemaker just to initiate the beta blocker?
No. We don't go too far. No. There are some certain contraindications for beta blocker therapy. There are certain indication for reduction of the dose if the patient is contraindicated due to very low blood pressure over sinus bradycardia, slowing heart rate below 40 and making him feel either dead or feeling very bad. It's just a rather stupid idea. In my humble opinion, you are entirely right. Good that you raised this question. You are right. Don't go too far. I remember there was a I participated in this Ivabradin story. Very good question that you raised this. That we can heart rate as a therapeutic target in sinus rhythm. Very good point, because in AF, completely different story. If you want me to suffer, you can ask me the question, what about AF? Would you consider beta blockers tend to, I will raise this issue as well if you want, but anyway, let's focus on bradycardia. At that point, when heart rate in sinus rhythm became a miracles target, people tend to say, why not we implant the pacemaker, even CRT, and then go for the total beta blocker, and that's it. I doubt that works, and I would not go that far. Not test it, and I would not test it if you ask me whether I would. Regarding AF, you didn't raise this, but I'm sure that you want to challenge me further. I think we don't have the clear evidence, but please remember that all these issues and controversies around beta blockers are retrospective analysis, and there is no prospective study on that. So I would keep this, and there are no guidelines which mention that there are differences. So I would keep this as over the whole spectrum, regardless in sinus rhythm or in AF. But in AF, you are right, heart rate is not this magic target itself.
Temos mais uma pergunta ali, bem no meio. Do meio para trás, é isto.
Teria algum beta-bloqueador de preferência?
Czy pytasz, jest jakiś lepszy lekarstwo dla beta-blocker? Czy jest jakiś lepszy? Albo czy pan lepiej lubi tak?
Well, that's a good story to tell you. There are several novel therapies. To be honest with you, I consider beta blocker as an element of targeting neuroendocrine activation. Whether you ask me whether I believe in neuroendocrine activation in heart failure, yes, I do. And if you want me to tell you about the evolutionary basis of a neuroendocrine activation, I can tell you a lot about this, because this is now a matter of our study in terms of kidney and in terms of sodium. We believe that sodium restriction is not good for heart failure patients. I'm not going to tell you that you should give salt to patients, but this obsessive sodium restriction is not good, because the body is clever enough. So neurohormonal activation exists. But our major drawback was that we were focusing all our interest on neuroendocrine activation as a target for therapy. Perhaps this is wrong. Now we need to broaden our view. There are a lot of novel concepts, and I think we need at least 1 decade to go out of this neuroendocrine story, which work. Whether I have anything better to target neuroendocrine activation than beta blocker, I doubt. At that moment.
Eu vou perguntar, enquanto aguardo a gente aguarda alguma outra pergunta da plateia, é o usual no Brasil, até porque ele está mais disponível no SUS, que o beta-bloqueador mais usado aqui seja o carvedilol. Entretanto, nós aprendemos com dados da hipertensão que quanto menos doses a gente toma, melhor seria, e quanto menos drogas a gente tem, melhor seria. Então, será que uma polipílula para insuficiência cardíaca, quer seja quando o paciente atinge a dose ideal ou no escalonamento dela, não seria interessante com uma droga de uso único, por exemplo, como o bisoprolol? Professor, I was asking that here in Brazil, different from Europe, the most used beta blocker is the carvedilol. Different from Europe, where bisoprolol is the most used one. And we learned from hypertension trials that the less the number of drugs and the less the number of times you take the drug, the best the adherence. What can be a barrier for us to reach the highest dose of that? So, as we discussed it before, and would like to hear from you, if a polypill, for example, with including a once-a-day beta blocker like bisoprolol and other drugs once a day could be a help for us to reach the guideline-directed medical therapy.
Well, this is a great story. If I were rich and have 20, 30 million euro for the trial, or maybe 50, I would definitely go for the guaranteed success for polypill in heart failure. It's not rocket science, it's just a very practical issue. I entirely believe that if we can offer a patient one pill with 3 or 4 components, I'm saying 3 because sacubitril/valsartan is given twice, so if a drug is given twice, polypill's concept is a little bit difficult. So bisoprolol, I would say 3 doses, 2.5, 5, 10, MRA, perhaps 2 doses, so it gives us 6 doses, and as SGLT2 inhibitor, it would give me maybe, but I would not go for 6. I have a very strong opinion. 4 doses would be good enough, and I'm sure that it is guaranteed success. And also from the economical standpoint, it would be really something because everybody could afford. So for countries like India or 1.6 billion people living there, or countries like African continent, a drug which is given once a day with and costs few cents is going to be a revolutionary approach. It's not rocket science. It's not about the new therapy, which is obviously important, but it helps and guaranteed success. It's my humble opinion.
Thank you.
Mais alguma pergunta? Eu vou perguntar a respeito de algumas coisas de retirada de medicação, ou qual seria, na verdade, a questão do remodelamento, né? Eu acho que a gente fica sempre na dúvida quando o paciente melhora sobre o que fazer. Eu acho que essa é uma pergunta frequente nesse momento, e eu vou fazer essa pergunta para ele. Professor, jak pacjent polepszy, jak całe serce się polepszy, co zrobić z tym pacjentem? Trzymać lekarstwa?
That's a very good question and very important clinical topic. As I mentioned, with the 4-pillar therapy, there are more, you are seeing this in your practice, particularly with the introduction now of ARNI. This patient tends to improve. Many of them tend to qualify as patients with heart failure and improved or recovered ejection fraction. Not even improved, but recovered, above 50. And the recommendation is very straightforward. It's great sign for the patient. Do not withdraw the therapy because we don't know who is going to deteriorate, who is going to suffer, who is going to get into the worsening heart failure. Sorry to say, continue the therapy and maintain the dose the patient was on before such a fantastic improvement. So we cannot have a personalized therapy in these cases. So continue the therapy. Sorry, but good luck and good sign for the patient, but we cannot guarantee that this is a remission, allowing us to stop and withdraw the therapy.
Alguma pergunta da audiência? Muito bem, eu acho que nós tivemos uma excelente apresentação, nós tivemos uma interação bastante interessante com o professor Ponikowski. ele que é um dos ícones da insuficiência cardíaca, dos trials, e o primeiro autor das diretrizes europeias de 2016. Então, é muito bom falar com alguém que sabe o que faz e escreve sobre o que faz. Professor, I was saying that it was a real pleasure to hear from you, a person that is so important in heart failure, an icon in heart failure, and the first author of the 216 guidelines of the European Society of Cardiology, which is what we use most in Brazil, much more than the American one.
I am very glad to hear that, but the word, if somebody is an icon, is the ticket for retirement, which is a good sign, but anyway, thank you very much.
Bardzo dziękujemy. Bardzo dziękujemy. Muito obrigada a todos. Eu acho que nós podemos encerrar a sessão. Obrigada.
Obrigado, Merck.